Hello, my name is Bilal Jalil, and we're going to talk about diabetic ketoacidosis today. It's very important for us to understand how insulin works, for us to be able to understand how DKA happens and how we treat it. For the context of this talk, there are two specific purposes that insulin serves. The first is to promote cellular uptake of glucose. This glucose becomes substrate for ATP generation. The other purpose of insulin is to inhibit fatty acid oxidation. In the state of diabetic ketoacidosis, there is a complete lack of insulin, thus impairing cellular glucose uptake, which will result in hyperglycemia. This hyperglycemia, in turn, will cause the kidneys to make a lot of urine because they will sense the glucose to be above threshold, eventually resulting in dehydration, but also causing a total body potassium deficit because of losing potassium in urine as well. The other effect of a complete lack of insulin in patients with DKA is that the inhibition of fatty acid oxidation goes away. This increases fatty acid oxidation, which results in increased ketone production. Ketones can be measured either in the urine as urine ketones or in the serum as serum ketones, and can also be measured as beta-hydroxybutyrate. The accumulation of these ketones will eventually happen because fatty acid oxidation is the primary fuel source for patients who are in DKA, and this will eventually result in a metabolic acidosis. These are the most common metabolic derangements that are seen in a patient with DKA. For diagnostic purposes, a diabetic patient with an appropriate clinical scenario having hyperglycemia and metabolic acidosis is usually consistent with a diagnosis of diabetic ketoacidosis. While hyperglycemia and a high anion gap metabolic acidosis are hallmarks of DKA, there are certain instances where we won't get these lab abnormalities to be present. The first instance is of patients who have insulin pumps in place, or those who have given themselves or have received insulin prior to arrival to an emergency room, or patients who are on SGLT2 inhibitors. These patients are at risk for developing what we call euglycemic DKA, where they won't have the hyperglycemia, but may have a high anion gap metabolic acidosis. The other patient population that may not develop acidosis but may have hyperglycemia are those who may have a concurrent metabolic alkalosis with a metabolic acidosis, such as those who have been vomiting. And so there you may have a normal pH. And so these are very good examples of patients who may be in DKA, may not have hyperglycemia, and may have a completely normal pH, yet still be in DKA. And this is why it's very, very important for us to know what the signs and symptoms are for diabetic ketoacidosis. Patients in DKA present with a constellation of symptoms. However, of all these listed, the most common are nausea and vomiting. There are some interesting signs in patients with DKA. To start off with, the fruity odor of their breath. This is usually related to acetone as a byproduct of fatty acid oxidation. The other interesting sign is Kussmaul respirations. This is a name given to deep, rapid breathing patterns, which is usually seen in patients with profound metabolic acidoses, such as patients with DKA. It is just as important to understand what precipitated DKA in order to prevent recurrences of diabetic ketoacidosis. I like to remember this with the I's as causes of DKA. The first three I'll start off with are insulin, infection, and infarction. Insulin can be an inadequate dose of insulin, an inadequate storage of insulin, or noncompliance with insulin. Infections are a very common cause of precipitation of DKA, and it's very important to rule out viral upper respiratory, viral gastroenteritis infections, pneumonias, and UTIs. Infarction refers to myocardial infarctions as well as strokes, as these are both conditions where there is a catecholamine surge, which can precipitate DKA. The other two I's are illegal and iatrogenic. Illegal for substance abuse, for alcohol abuse, which usually results in noncompliance, but can also result in a catecholamine surge. And iatrogenic is where we have either made medication changes, such as adding steroids or adding anti-diabetic medicines, such as SGLT2 inhibitors, that can result in diabetic ketoacidosis. The other three causes that I like to stress on are three P's: pregnancy, pancreatitis, and insulin pump failure. All three of these can also result in precipitation of DKA and are important to recognize. Now we come to, well, how do we treat DKA? Almost every institution should have a DKA protocol in place, which is usually a concoction of insulin and IV fluids. And we're going to try to understand better how DKA protocols work. The one thing I do want you to remember is that the therapeutic target for insulin is not to lower the glucose level, but rather to correct acidosis and close the gap. If insulin results in reductions in glucose levels, we add sugar water to increase blood glucose levels to ensure that we can correct acidosis and close the anion gap. I'm going to attempt to break down a DKA protocol and dissect it so that you can understand it better. The first ailment that we're going to treat with the DKA protocol is acidosis. Acidosis is resulting from fatty acid oxidation and production of ketone bodies. And so the way to stop this process that's causing acidosis is to treat patients with insulin. If you expect a lag time of more than 30 minutes in an insulin drip being started, it may be advisable to push a bolus dose of insulin IV before starting the drip. It is also important to note that patients with diabetic ketoacidosis usually tolerate acidosis fairly well, sometimes even in a range of 6.9 to 7.0 pH. The next thing to treat with the DKA protocol is hypokalemia. If you remember, we have a total body depletion of potassium because of hyperglycemia and the diuresis associated with it. There are patients who will come in with a severe metabolic acidosis that will cause cellular shifts, and on labs on initial presentation will have hyperkalemia. As soon as you start treating their DKA, their potassium will drop considerably, and it's important to keep an eye on this. The most important thing that you need to remember is that if you have critical hypokalemia, which is less than 3.0, you should probably replete your potassium before you start your insulin drip, as this will likely cause the patient's potassium to drop even further. The important thing also to remember is most patients with isolated hypokalemia will tolerate it well. When you have a combination of hypokalemia with hypomagnesemia, those patients may get into trouble. So it's also important to keep an eye on your magnesium levels. The last thing to treat with the DKA protocol is dehydration. These patients in DKA are profoundly dehydrated primarily because of hyperglycemia, which causes diuresis. And so these patients should be given 2 to 4 liters of crystalloids up front in the emergency room and then started on maintenance fluids by the protocol. The protocol will specify a fixed rate of crystalloid when their sugars are above a certain threshold, and they'll transition to a dextrose-based solution once their sugars drop below that threshold. At my institution, that threshold is 250, and so we'll transition from either NS or LR to D5NS or D5LR once sugars drop below 250. You're probably thinking, if a DKA protocol can take care of my patient in DKA, what do I need to do? There are some very specific things I want you to look out for in these patients. The first is to look for a precipitating cause. If you can find a precipitating cause, that can potentially prevent recurrent episodes of DKA in these patients. The second is respiratory support. These patients are going to be very tachypnic, have Kussmaul respirations, sometimes also have altered mental status that may require intubation for airway protection. I try to practice in a way that I try to avoid intubation in these patients and have successfully been able to use high-flow nasal cannula such as Airvo or Optiflow to be able to keep up with the patient's demands for minute ventilation. It is important to know when you would need to modify the DKA protocol. Two specific patient populations that I can think of. The first is end-stage renal disease patients. These patients don't make urine, they don't get dehydrated or hypokalemic like our regular patients with functional kidneys. And so be very cautious of overzealous IV fluid resuscitation or potassium resuscitation. Most of these patients will not need the initial bolus of IV fluids that's given to them for DKA and can be maintained on just maintenance IV fluids with the protocol. The second population is heart failure patients, and again are at risk for pulmonary edema from overzealous volume resuscitation, and so being cautious with giving them upfront boluses of fluid may be advised. Another scenario is where a patient's metabolic acidosis and anion gap are getting worse despite being on the DKA protocol. These may be people that you need to increase your insulin doses from 0.1 to 0.2 or even 0.3 units per kg per hour to achieve improvement in acidosis and the anion gap. Lastly, insulin pumps. If you do not have expertise in knowing how to use these pumps or do not have endocrinology available in-house, the best advice would be to discontinue using this pump and transition patients from an insulin drip to subcutaneous insulin. They can restart using their insulin pumps as an outpatient under the guidance of their specialists. This brings me to the last part of this talk, which is transitioning patients from IV insulin to subcutaneous insulin. This is usually based on lab parameters which involve improvement in the metabolic acidosis and closing of the anion gap. The arbitrary numbers I like to remember are a bicarb above 18 and an anion gap less than 12. There are three important things to keep in mind when transitioning a patient off of an insulin drip to subcutaneous insulin. The first is to make sure we allow at least a 2-hour overlap of subcutaneous insulin with intravenous insulin. The second is that the patient's going to need to eat after being transitioned, and so making sure before we transition that there are no barriers to oral intake, such as altered mental status, dysphagia, or nausea or vomiting. The last part of transitioning is to monitor for a recurrence of DKA, and I usually check a chemistry about 6 hours out from transitioning to make sure that the patients aren't going in the opposite direction. And this brings us to the end of this video. Please do hit the like button if this video was helpful to you. Leave comments for feedback or for requesting new videos. And please do subscribe to this channel. Thank you.